Dr. Williamson, I want to move on now to the topic of VCJD. You attended a Sakti meeting on the 16th of April 1996. We've got the minutes of that meeting. NHBT 5088_013, please, Paul. And if we go over to page 6, please. We can see there an ad hoc meeting had been held at the Royal College of Physicians of Edinburgh on the 9th of April 96 to review the possible implications of the recently reported cases of variant CJD for the transfusion services. This was in recognition of a change in perception of CJD as potentially infectious until otherwise proven. This was referring, I think, the recently reported cases to a Lancet paper. Is that right?
Yes.
And you believe you may have read the Lancet paper before the meeting, but certainly at that meeting you became aware of the risks of transmission. We then go on to see in these minutes it was agreed that the first priority at this stage was to improve the level of knowledge so that appropriate decisions could then be made regarding donor selection, handling of blood components, etc. And 5 actions were agreed. You've described them in your statement as looking at Prion research and epidemiology, yes, broadly. Can you explain to us the thinking behind those 2 strands, Prion research as one strand and epidemiology as the other?
Yes. So classical CJD had been around for decades, and various studies had been done to see whether that could be transmitted through transfusion. But globally, across the world, there had not been any proven cases. So setting that to one side, we now had variant CJD, and we could not assume that that could not be transmitted. In other words, we had to assume there was a problem till proven otherwise. And the 2 ways we thought we could get some evidence on that was firstly to work with the CJD surveillance unit in Edinburgh, which had been set up in the wake of the BSE epidemic to track whether CJD was increasing in the UK on the back of that. And it was that unit which identified variant CJD as a new disease and described it in the Lancet in 1996. So they received information about every case of classical and variant CJD in the UK. And it seemed that that would be a good way to try to establish whether there was an excess of transfusion recipients turning up with variant CJD, or indeed whether there were people who developed variant CJD who had been blood donors, and therefore give us a route to see what happened to their recipients. So a study was set up, led by Dr. Pat Hewitt, called the Transfusion Medicine Epidemiological Review. It was given a slightly coded name for sensitivity reasons. And that allowed us a 2-way look back, if you like. So if a person developed variant CJD who had been a blood donor, the recipients would be, the identity of the recipients would be traced, and this was all done with ethics approval, and the names given to the CJD surveillance unit, so that if they developed variant CJD in the future, there would be a match, if you like, and so that would provide some evidence that variant CJD could be transmitted. Conversely, if a person developed variant CJD who had been transfused, then the details would be given to the blood services, who could track all the identity of all of the donors. And then they would be given to the surveillance unit to see again if there was a match that way round. Now that was obviously fraught with a number of ethical issues in terms of what the recipients and donors were to be told about the fact they were in a look back. But it seemed the only way in the human population to try and get a handle on whether there was really a risk or not. from transfusion. And then the second strand is what was known about the science of prion diseases, not something which blood service people had any expertise in at all. And so we were very dependent on the Spongiform Encephalopathy Advisory Committee and their scientific networks to educate us and to keep us up to date with what was happening in the field, which I'm afraid largely involved experimental animals as models of prion disease. Obviously, we'd had BSE in cows, but there were other ways of researching prion diseases that might apply to humans.
And we can see one of the actions here under Roman 4, number 4, in view of the possible transmission via buffy coats, Dr. Gillen will produce a paper on the potential role of leukocyte depletion of cellular blood components in providing protection from the putative CJD agent. And in November 96, you put a proposal together for the Msbt on the research you thought was required, which included exploring the benefits of leukocyte depletion. Is that right?
Is that the paper with Dr. Miner?
Yes.
Yes. So Dr. Philip Miner, whose name is mentioned here, was an infectious diseases scientist at the National Institute for Biological Standards, and he knew about prions and I knew about leukocyte depletion. So we put a paper together which went up to Msbt. We didn't ever get a reply directly from Msbt, but in papers I've been sent by the inquiry, it seems that it was passed on to a research grouping that the Department of Health was using, who apparently didn't think much of it. So it wasn't taken any further forward at that point.
Just at this point, can you give us an explanation, much as you did earlier today, of what leukocyte depletion is?
Yes. So if you take human blood, you have the red blood cells that carry oxygen, the white blood cells, also known as leukocytes, which fight infection. There are little things called platelets that help the blood to clot, and then there's the liquid yellow plasma. And the question was, or one of the many questions, where in the blood do these infectious prions sit, if they are there at all? And so the scientific evidence was telling us that if you could get really, really pure red cells, no prions, really, really pure platelets, no prions, that they seem to be sitting in the white blood cells, leukocytes, or in the plasma. So leukocyte depletion is a way of removing as many white cells as you possibly can, 99.9%, say, from either a bag of red cells or a bag of platelets, and later on also a bag of plasma. And it was done by filtration. And we had been doing that since filters became available in the late 80s, early 90s, for certain patients who were having horrible reactions to their transfusions, shivering and shaking and fever. And it was discovered if you filtered out the white cells, these reactions could be prevented. So that's why these filters were developed in the first place. And so there were filters on the market already in 1996, 97, which we could take and investigate to see whether we could apply that white cell removal to every blood component which we supplied.
And in terms of the filtration, just very simplistically, where did that happen?
So
and
early,
when in the process?
Yes, well, originally, these filters were sold to hospitals. So they were hung at the patient's bedside as the blood was dripping in. It would be passed through the filter. And with colleagues in East Anglia, we did a study in the early 90s of this bedside filtration and how useful it was. And actually, we didn't think bedside filtration was the way forward anyway, because the blood was already quite, the blood might have been stored for a week or two, the white cells might have broken up. And so we were minded to move filtration into the blood centre anyway, even before variant CJD came along. And certainly if we were going to use it as an important means of minimising the risk of variant CJD, it would have to be done in the blood centre with proper standard operating procedures, quality control, measuring the white cells that came through, and so on. And that was, in fact, what happened.
In October 1997, 2 papers were published which you've described in your statement as chilling. What were they, and why was it chilling for you to see those papers?
I mean, that was that was my personal reaction. So we had BSE, tens, hundreds, thousands of cattle, and variant CJD had appeared in the population, very small numbers. And there was a question about whether variant CJD had somehow arisen in the population as a result of the BSE epidemic, or if it was just a new condition by itself. And 2 papers appeared in scientific journals, essentially showing by 2 different mechanisms that the fingerprint of BSE and the fingerprint of variant CJD were the same. So that really nailed it, that variant CJD had arisen through people eating BSE contaminated beef and other things made from cows. And that in turn opened up the possibility, firstly, that we'd have thousands of people infected and affected by variant CJD due to eating beef. But for us particularly, the horrible prospect of tens or hundreds even of people further infected through transfusion. And so that was pretty scary, very scary.
And that October, you prepared a paper with Dr. Flanagan and Dr. McClelland assessing strategies to minimise the risk of transmission. Can we have that on screen, please, Paul? NHBT 304564. I'm just going to read a few sections of it, and then I will ask you about it in a moment. This paper considers ways of minimising the theoretical risk of transmission of Nvcjd by transfusion. The potential risk that this disorder might pose to the blood supply cannot yet be assessed. In particular, data are not yet available on the transmissibility of Nvcjd by blood transfusion. Experimental and epidemiological evidence on the transmissibility of TSEs by blood were reviewed at a recent WHO consultation. It was concluded that there's no proven or even probable instance of transmission of CJD by blood components and blood products. However, recent evidence suggests that the transmissibility of Nvcjd in an experimental system differs from that of classical CJD. Thus, Nvcjd may differ significantly in its behaviour from classical CJD in respect of its ability to be transmitted by transfusion. And then you've got the heading Possible Approaches whereby the theoretical risk of transmission might be minimised. Firstly, exclusion of donors who could be at higher than average risk of acquiring the infection. And it indicates that a number of exclusion criteria have already been implemented in the UK with regard to CJD. The exclusion of recipients of pituitary hormones of human origin, recipients of corneal transplants, family members of sporadic and iatrogenic CJD cases, and recipients of dura mater, which was to be implemented shortly. The second option was the application of screening tests, and obviously there was no test at that time, and there is still no screening available. Thirdly, the application of physical or chemical processes to inactivate or remove the infectious agent. 3 options are given: plasma fractions, blood components, and leukocyte depletion. It's right, isn't it, that you were primarily involved in the leukocyte depletion work in your research?
Yes. So with regard to plasma fractions, BPL and the Protein Fractionation Centre in Scotland were the leading organisations there. With regard to blood components, methods of virus inactivation were beginning to appear, as we discussed this morning, but we had no reason to imagine they would work against these prions that cause variant CJD, because they are extremely resistant to chemical inactivation. So actually, apart from minimizing the amount of plasma to which patients were exposed, leukocyte depletion was really the major thing that we had to offer in terms of manufacturing to try and reduce the risk.
And in this paper, you've said, given the experimental evidence that appears to identify TSE infectivity in the buffy coat, it's possible that leukocyte depletion would be an effective mechanism to reduce the likelihood of transmission by blood.
Yes, I should explain the buffy coat it's the white cells plus the platelets. And in animal studies, that had been shown to be the portion of the blood that had a lot of prion infectivity in it.
And then two other options: promotion of good transfusion practice. So what you were just saying a moment ago about not giving too much to patients, and then substitutes or alternatives to human blood products. It's right, there was extensive discussion about excluding previously transfused donors as well.
Yes.
Through a number of the Msbt meetings particularly. But it wasn't implemented until March 2004. What can you tell us about that?
That's right. That really came into play a little bit later, because it was thought, I think, at the time, leukocyte depletion was the thing that we needed to get on and do, because it was doable. It could be applied to all blood components. We wouldn't lose any donors. It was something that the blood services could implement. It wasn't quick, and it was certainly not easy, but it was very doable. The concern about excluding previously transfused donors was how much of the blood supply would we lose. The estimates were anywhere between 5 and 10% of all donors had themselves been transfused, because for many donors, if they knew they'd been transfused in the past, they wanted to give something back. So I think the donor population was a little bit enriched with previous recipients. So there was real concern that the NHS would suffer and patients would suffer if there weren't enough blood on the shelf, because we had suddenly excluded previously transfused individuals. And the discussions did go backwards and forwards between the blood services and Msbt for quite a while. But leukocyte depletion was agreed with Msbt to be the blood services' top priority, along with the separate exclusion of UK plasma from fractionated components, plasma products.
So in terms of the leukocyte depletion, a feasibility report was prepared in February 98, and then in July 1998, the Secretary of State announced that leukocyte depletion would go ahead. You've described in your statement that move as a high-cost, high-precautionary decision. What do you mean by that?
Well, it was going to add a significant amount to each unit of blood. By that time, there was cross-charging in place, so we'd had to work out the cost of each unit. And leukocyte depletion was going to add something like £20 to a bag of blood, which would otherwise cost something like £100. So it was far more than any test, the cost of any test that we'd implemented. And highly precautionary, because in 1998, there had not been a single case of transmission of variant CJD through transfusion. And we didn't know if there ever would be. But on the other hand, it would have been quite wrong to sit on our hands and wait until a case occurred. And in fact, sadly, there were cases, but there were three clinical cases. And the first case wasn't reported till 2003. So if we'd waited for another 5 years, many more people potentially could have been infected. So it was absolutely the right decision. And it was made in quite short order after the risk became apparent.
You said earlier that with new variant Nvcjd, you had to assume it was transmissible until it was proven otherwise. Was that the view of most that involved in the transfusion service at the time?
So I think so. I don't recall any dissent about the fact we were going to be doing this, doing leukocyte depletion.
The inquiry has looked at a lot of the documents and the discussion around HIV and hepatitis C in terms of how the risk was viewed at that time. In your view, and your language was very different to that in relation to HIV and hepatitis C. Why was there such a change in attitude to risk in relation to VCJD compared to what had been done in relation to HIV and hepatitis C?
Well, I guess we had learned from the mistakes of the past that if things took a long time to be decided, or where the risk was uncertain, there was much more use of the precautionary principle, which is designed to cover the situation where you may have a risk. It's not very clear what the magnitude of the risk is, but if there is a risk and its outcome is dreadful, as this would have been, you have to act. You can't wait for data to become available. And of course, we had learned from the HIV and hepatitis C experiences. So I think we were everyone was in agreement. We had to get on and do what we could.
Leukocyte depletion was in operation by the 1st of November 1999.
Yes.
What were the operational challenges to make that happen?
Well, the whole blood supply chain, really, from the donor session to the point where blood went to hospitals, had to be re-engineered from start to finish. So at the donor session, the blood, we wanted the blood to be mixed, not just by the odd shake, but on a physical shaker to make sure there weren't any clumps that were going to block the filters. There was discussion about what temperature the blood should be kept at before it got back to the blood center. Should it be cold? Should it be kept warm? How quickly could blood be got back to the center? What was the optimum time to filter? How high did you hang the filters? There were all sorts of operational things. And then the challenge of measuring and assuring ourselves and clinicians and patients that the filters had worked. You can count white cells in a blood counting machine normally, but when you've removed 99% of them, those counters don't detect them. So we had to develop novel ways of counting the white cells. And then, since we couldn't count every single donation, because we made something like 2.5 million individual components, we had to work with statisticians to come up with a sampling plan that would provide the assurance that the system was what was called in control. In other words, it was doing what we said it needed to do. And then plans for increasing counting if there were any concerns that it wasn't working terribly well. Then there were all sorts of, that was all on the critical path to implementation. In other words, we couldn't implement till we had set ourselves a level of leukocyte removal that we wanted to achieve, and the means to measure it, and the statistics to assure everyone that it was working. In parallel, there were lots of other questions that were being pursued alongside the race to implement. Things like, well, do we know what types of white cells we're removing? So there are different sorts of white cells. Maybe the prions are in some sorts and not others. We'd better find a way of being able to sort out the different sorts of white cells when there are hardly any left to look at, Does the process protect patients against some viruses that sit in white cells? So cytomegalovirus, very bad news if you're a newborn baby or immunosuppressed. HTLV, which was not being tested for at that time. The papers had gone backwards and forwards to Msbt, and previously a decision by them not to screen, but it was white cell associated. Perhaps we were going to provide some protection. So we did studies on those things alongside. And then the important donors who were carriers for sickle cell anemia, and many of those were important because they had blood groups that were useful for sickle cell patients. But supposing those red cells from those donors blocked filters. So there were lots and lots of questions to be answered alongside implementation. So we had to sort out what we needed to get right before we could go live, and what could be carried on once we'd gone live. So I think achieving it in 15 months was as fast as could be done. One, I mean, then I haven't even mentioned the blood bags and the manufacturers. So manufacturers made blood filters, but not 2.5 million a year. So we had to talk to a number of manufacturers. We couldn't rely on one in case they had supply problems. Then we were collecting platelets by apheresis. Those platelets also had to be white cell removed. Did the apheresis machines do it adequately? And so on. To begin with, filters were bought separately from blood bags. And that was one of the reasons for the high cost. So you had to buy a filter, you had to buy a blood bag, you had to buy a machine to dock those together, to join them together in a sterile way so that the blood could go through the filter and not be contaminated. Eventually, manufacturers, in discussion with us, manufactured these as a single unit. And that brought the cost down, and it made everything much, much slicker because the filter was already incorporated. So there had to be tendering exercises for manufacturers of filters, blood bags, apheresis equipment, and so on. And then, of course, communication with hospitals, with hospitals primarily, and through them to patients, to the media, to politicians, and so on. So there was an awful lot to do.
And then in terms of the decision to import plasma, was that something you were particularly involved in, or was that sat with someone else?
Well, I did become involved in that because, so we talked this morning about techniques to inactivate viruses in fresh frozen plasma. We knew they would do nothing against prions, but we were in the process of trying to implement methylene blue treatments of plasma, of UK plasma. And that was going on. But at the same time, once we had leukocyte depletion in place and UK plasma was not being used for fractionated plasma products, attention turned to the possibility of importing plasma to be used as fresh frozen plasma and cryoprecipitate for patients. And I attended various meetings of Msbt where the blood services were asked to investigate the possibilities of that. Initially, for the entire supply of fresh frozen plasma, which was somewhere over 100 tons. So we, I think through a plasma broker, we initiated a search, predominantly in the USA, but also elsewhere, to see if we could find 100 tons of plasma that would be suitable for use as fresh frozen plasma. And that turned out to be really quite difficult. I suppose because for a while, the UK plasma was not contributing to the global supply of plasma products. Plasma was very difficult to find. The price of it was going up exponentially. And of course, we were concerned that if we sourced plasma from anywhere other than the UK, the virus risk was going to be higher. And certainly from the States, we knew that, depending on whether it was an urban setting or a rural setting, and whether it was HIV, hepatitis B, hepatitis C, we could be looking at virus risks that might be 4 times higher than the UK or up to 9 times higher than the UK. And we didn't want to swap one risk for another, take variant CJD out of the equation, but we were bringing in more viruses. So our first sort of principle was that any plasma that was going to come into the UK as fresh frozen plasma was going to have to be virus inactivated, whether by methylene blue or by the solvent detergent method. That was the first sort of given. And of course, that added to the complexity of the thinking, because the blood services didn't have capacity to methylene blue treat 300,000 units of fresh frozen plasma. We just couldn't have fitted it in, really. So there was discussion with a company called Grifols in Spain, who were possibly going to do that. And then, of course, we wondered about solvent detergent treatments. But again, there was concern about pooling. And while all these options were being assessed, plasma was becoming harder to get and the price was going up. We were also aware, through the serious hazards reporting system, of a condition called transfusion-related acute lung injury, a very serious and sadly occasionally fatal condition of acute breathlessness and low oxygen after receiving a plasma transfusion. And the realization that this was due to antibodies in the plasma. So it was an immune reaction between the plasma and the recipient. And for reasons I can explain if you wish, male donors didn't cause this effect. So we were looking for non-UK, virus-free male donor plasma at about 100 tons, 120 tons. And that was very, very difficult to obtain. So in the end, well, for a while, Msbt suggested that we use the methylene blue treatment for plasma for babies and children and the solvent detergent method for adults. But no decision was forthcoming, and it got to be a little bit of a catch-22 where plasma suppliers in the States were not very willing to talk to us until we had a definite decision that this is what we were doing. But at the same time, Msbt weren't getting a mandate until a source of supply could be guaranteed. So it got a little bit of a catch-22, as I say. And so in the end, the recommendation from Msbt, which turned into an instruction, was to import plasma for babies and children only, and the supply of fresh frozen plasma for adults was to continue from UK sources. It was a bit more complicated than that because the babies and children were actually, the precise detail was people born after the 1st of January 1996. Now that's the date when the UK food supply was considered safe from BSE. So it seemed there was some logic in saying, well, we must absolutely protect people who have not been exposed through food. But if you think about it, that population over the passage of time gets bigger every year. Both individuals get bigger and the number of patients get bigger. So we had to figure out a supply that would grow as the recipient population grew. And that was doable, and that was what was done. So plasma came from volunteer donors because that was the other basic rule. We didn't want plasma from paid donors in the States. So it was all from community volunteer donors in the States. It came to the blood service in Britain. Individual units were methylene blue treated without pulling them together. By that time, manufacturers had put in a filter to remove the methylene blue, which greatly reassured the pediatricians, and that was what was provided for any patient born after 1st of January 1996.
And just for completeness sake, the recommendation by Msbt on the importation of FFP was on the 22nd of October 2002.
Yes.
And it wasn't announced then by the Department of Health until the 16th of August 2003.
Yes, yes. We never really got to the bottom of why that bit of the process took 10 months, but that was correct.
I want to now just look at some of the committees you sat on, particularly in your later roles within the NHSBT, to complete the picture of what you were involved in, before we then look at the SHOT reporting mechanism. You were a member of the Standing Advisory Committee on Transfusion Transmitted Infections from 93 to 97. And the primary remit of that committee was to produce the chapters in the guidelines for the UK transfusion services. Is that right?
Yes.
And they acted as an advisory committee to the UK blood services. The chair of Sakti is also a member of the Joint Professional Advisory Committee, JPAC. And they fed information and recommendations into the JPAC committee. Is that right?
Yes.
As far as you're aware, were there any formal links between Sakti and the Msbt?
There were not, but I do remember discussions as to whether there ought to be.
What problems did the lack of formal links cause, from you, as far as you were concerned?
I think each committee lacked insight as to what the other was discussing. So there was a communication route, but it went from chair of Sakti to JPAC to Dr. Robinson to Msbt. And my understanding is that Msbt, and from things I've read, was very confidential, shall we say, at that time. The minutes were confidential and supposedly not to be shared out with members of the committee. I had to present to Msbt on several occasions, but I was not allowed in the room until we got to my item, and then I was out of the room again. It was a very sort of closed environment in a way. And although on paper it was clear that the remit of the two committees was different, there was obviously going to be overlap. And I think if, for example, the chair of Sakti could have been at least an observer in the Msbt meetings, there would have been a lot more insight from Sakti's point of view as to what work we should have been doing to help Msbt reach the high-level decisions for which they had responsibility, to be advising departments of health and health ministers.
In 2008, the Msbt was replaced by SABTO, the Department of Health Advisory Committee on the Safety of Blood, Tissues and Organs. And you were a member of that SABTO committee between 2008 and 2016. In your statement, you've reflected on how the creation of SABTO led to a very different way of policy making. And why do you think SABTO made a positive difference to how policy was made?
Well, there were a number of aspects. Well, firstly, it was chaired by a practicing clinician. Msbt had been chaired by one of the deputy chief medical officers, so someone from within the Department of Health. But SABTO was chaired by a clinician, and it became an advisory committee to the department rather than a committee within the department. It had a large membership of clinicians of all different sorts. There were lay members, very important lay members. The blood services were represented. And importantly, they had observers from a number of organizations which, in a way, surrounded the work of SABTO. So there was an observer from SHOT, there was an observer from JPAC, the chair of JPAC attended, the chair of the Chief Medical Officer's National Blood Transfusion Committee attended, and so on. So there was much more open dialogue and much more transparency as to what was going on. Then the minutes were published on the website along with most of the background papers. There was very visible analytical support, which actually NHSBT made use of at various points, and that was wonderful. So the Department of Health's Economics, Statistics and Operational Research Team, bit of a mouthful, ESOR, could be presented with a problem, and they would analyse it very systematically and present information that would contribute to a decision. There was a decision-making framework which members of SABTO were inducted in when they became members, and that was a way of thinking about problems in a very structured, a very transparent way. Every decision was reached in a very systematic way. So, for example, Hepatitis E, which was a new threat. So a working group was established. There would be a written remit which would be agreed with SABTO. The working group could co-opt experts as they wished. There would be a timeline for producing a report. The analysts would help crunch all the data. We had a health economist providing a view on the cost, although cost was only but one factor in the decision-making. The working group would then present to the whole of SAPTO, and SAPTO could agree with the working group's recommendation or overrule it. There would very often then be a wide consultation exercise with the professions and lay stakeholders as to what the decision was minded to be. And then a final recommendation would go to departments of health. So it was all absolutely transparent. And because there was a structured process, there wasn't sort of months and years of toing and froing between SAPTO and blood services. It was, we'll do this short piece of work in a very systematic way, and we will come up with a recommendation. And if the recommendation is not to proceed with something, we will decide when we're going to review it again or what new information would cause us to review it again. So it was much more logical and structured, at least from the point of view of someone sitting in blood service.
From 2007 to 2016, you were a member of the Chief Medical Officer's National Blood Transfusion Committee. That committee was focused, I understand, on transfusion practice.
Yes.
And improving that interrelationship between the blood services and the hospital clinicians.
Yes.
And it also included education work in a broad sense. That's something you'd been involved with throughout your career in terms of providing education on best transfusion practice, wasn't it? And another element of that best blood transfusion practice was the Easter study that you undertook.
Yes.
In the year 2000, so before you were on the CMO committee, but perhaps it's worth us picking that Easter study up. If we can have WITN 0643026, please. There's two papers we're going to look at. This is the first, published in Transfusion Medicine in 2009. We can see in the summary that the study provides data on National Blood Service red blood cell, platelet and fresh frozen plasma recipients, independently sampled by monthly quota from 29 representative hospitals over 12 months in 2001 to 2002. We carry on down the main ECMGs. That was the epidemiology and survival of transfusion recipients case mix groups. Broadly, was that you categorising the transfusion recipients into why they had the transfusion?
Yes, exactly. There had been surprisingly few studies in the literature, although the difficulty of doing this probably made you realise why. But they tended to say, well, it's surgical or it's medical. And actually, we wanted to look at this differently because a patient might be surgical this week and medical the next week, but it's the same patient. And it seemed a better way of doing it to consider the patient in the round. So we didn't know what we would find. The perception is it's all trauma or it's childbirth or whatever. But in fact, at that time, so this is 2001, 2002, for red cell transfusions, the biggest single group of patients receiving transfusions had disorders of their digestive tract.
If we just zoom out, we can see that. So there's the very specific statistics provided in the summary where digestive, it was 19% of red blood cell recipients, musculoskeletal 15%, obstetrics and gynecology 10%. It carries on, and then at the very end of the summary, digestive and hepatobiliary indications emerged as the top reason for transfusion in red blood cell and FFP recipients, and was also a frequent indication in platelet recipients.
Yes.
Were those findings something of a surprise to you?
Yes, I think they were, actually. I don't think we had realised that taken together, so these conditions would be anything from stomach ulcers, colon cancer, cirrhosis of the liver, altogether were the single biggest reason that patients would receive red cells.
And was that information then used in focusing education towards particular groups of clinicians, or was it accepted that that's just what was needed for these patients?
I think was published in 2009. I think by then, the various aspects of what became known as patient blood management were very well established across all aspects of medicine and surgery. So there were certainly things which could potentially be done for certain types of surgery, such as the use of cell salvage, where the blood is collected, washed, and transfused back to the patient. Certain drugs that could be used, and so on. But the main thing we did with this data, particularly when we got on to looking at survival, was we fed it into the SABTO's various risk assessments. So in considering the benefits of certain safety initiatives, the analysts were able to look to see what sort of patients would receive blood and therefore the impact of any further safety steps that they wanted to take.
And then we have a paper from 2015, WITN 0643027, which I think is the paper you were flagging to us earlier about survival, transfusion in adults, 10-year survival of red cell plasma and platelet recipients following transfusion. We can see under the heading summary that the objective of the study was to determine the long-term survival of adult recipients transfused with red blood cells, platelets and fresh frozen plasma in England and Wales. And then under the results and conclusion section, the median age interquartile range of adult recipients, it was 70 for red blood cell, 66 for fresh frozen plasma and 62 for platelets. And the 10-year survival for adult RBC, FFP and PLT recipients was highest for RBC recipients at 36% confidence interval compared with 30%. If we carry on to the conclusion, the study shows that survival following transfusion in England is broadly similar to that reported in other wealthy nations. More than 70% of recipients die within 10 years of transfusion, but long-term survival is common in younger patients, greater than 80% 10-year survival in red blood cell recipients aged 16 to 39 years. I think that's what you were highlighting to us earlier when we were discussing the 5-year survival.
Exactly. And there was a paper alongside this one studying survival in children.
Yes, we have that. WITN 0643028.
And what we'll see is a lot of blood is used in premature babies. And sadly, not all of them survive. But those who do survive, and children who are transfused with red cells, actually survive a long time. So again, it was at least 70% overall are long survivors because they have been transfused for some, perhaps, major surgery, and therefore, as we've said, they're at risk for late complications. And it's probably just worth emphasising in both the children and adults, the deaths were all due to the underlying reason why people were transfused. So the transfusion wasn't causing the deaths. It was the natural course of whatever illness the person had. But it did flag up these long survivors who probably, in the case of many children, would then go on to have a normal lifespan.
The final topic I want to talk with you about, Dr. Williamson, is the shot mechanism. In 1994, you were asked to convene a group to develop a UK-wide reporting system for infections and serious side effects of transfusions. Why was there felt to be a need for that mechanism to be set up?
Well, I think a number of things came together. Obviously, before there was a test for hepatitis C, no one knew what the burden of non-A, non-B hepatitis was. But even if there had been, before we started screening, no one knew how many transmissions there had been. No one knew how many HIV transmissions there had been. And then, although screening was in place for both of those, there was a sense that there were still possibly hepatitis B transmissions, even though we were screening for hepatitis B. we knew that some platelet transfusions had caused bacterial contamination in the patients. And then there were a whole lot of immune complications, such as transfusion-related acute lung injury, which were serious and sadly occasionally fatal. And we had no idea of the magnitude of those. At the same time, Dr. Brian McClellan was doing nice work, and the same in the States, looking at transfusion in hospitals and realizing that while blood services worked to good manufacturing practice and every process was very well controlled and very few mistakes were made, it was a bit different once you got to the busyness of a hospital. And sometimes, unfortunately, patients would be transfused with a bag of blood that was perhaps intended for another patient. And of course, if it wasn't the right blood group for the patient, then you could have a serious ABO incompatible transfusion, which could be a very serious thing if it wasn't noticed quickly, and sadly, again, potentially a fatality. So there were all of these things coming together, and then Dr. Robinson and Professor Cash were attending meetings in Europe in preparation for there being an EU directive on blood and transfusion. And they could see that reporting systems were probably going to be mandated as part of that. So they wanted to get ahead of the game and set something up in the UK.
So we have the minutes of the first meeting of the working group NHBT 307853_001. The first meeting was on the 21st of December 94. And if we go to the section under remit of the group, we can see that the remit was to produce recommendations for the reporting of serious complications. This will require a definition of what is a serious complication and will involve the design of a system for reporting. And secondly, to educate in the field of hazards of transfusion in order that reporting should be as comprehensive as possible. And then if we carry on to page 4, viral transmission, there was thought to be probable under-reporting from hospital clinicians and lack of awareness by general practitioners, so that some feed-in to GP practices would be required. What was this concern focused on?
So I think this was the issue we were discussing this morning, that if hospital clinicians and GPs, so if a patient developed jaundice, as an example, would the hospital clinician and or the GP know that they'd had a transfusion? And if they did, would they think of the transfusion as a possible source of infection? To some extent, we had, of course, made everyone aware that we were now screening for hepatitis C. And so we were conscious that clinicians would think that viral infections from blood were a thing of the past. And that the risk was no longer there. So we had to give them two slightly conflicting messages. Blood is very safe, the risk of viral transmission is very low, but it can happen. And it was that "but it can happen" message we had to try and get across. So I think that was what that refers to there.
And it's picked up on page 5 as well, and in fact this picks up some of the discussion that we had earlier. There was considerable discussion as to the existence of feedback mechanisms for new cases of post-transfusion hepatitis in terms of tracing transfusion history. Awareness amongst clinicians and general practitioners may need to be increased, perhaps via a CMO letter. Another possible source of information would be via the PHLS, but this might breach confidentiality. And then there's some initial discussion about how a reporting system might work at this meeting. The mechanism, the serious hazards of transfusion mechanism, the SHOT mechanism, was launched in 1996. Is that right?
Yes. Well, I think, or 95. The
first editorial in the British Medical Journal, sort of highlighting it, was in November 1996.
Oh, well, I beg your pardon, it was 1996, yes, because we wrote that at the time of the launch.
So if we could look at that, WITN 0643051, please. And it starts, how safe is blood transfusion in 1996? Despite recent publicity surrounding contaminated blood bags and hepatitis C virus, it's probably safer than it has ever been. More rigorous donor selection, improved viral screening tests, tighter quality control and accreditation of hospital laboratories have all played a part. But there is no room for complacency. As was highlighted by an editorial in the BMJ 2 years ago, preventable deaths after transfusion still occur. And if we go to the bottom of the page, SHOT aims to improve transfusion safety further by analysing reported information on transfusion hazards and translating the findings into transfusion service policy, clinical guidelines and training. Similar systems already exist for confidential reporting of maternal, infant and perioperative deaths, and their value is widely appreciated. The success of the scheme will depend on the participation of all staff administering blood, so its activities are being directed by a steering group with wide representation from royal colleges and professional bodies. The system will be confidential, with no possibility of identifying patients or hospitals from the final dataset. The need for anonymity is paramount to encourage reporting without prejudice to the individuals or institution concerned. Then over the page, hospital haematologists responsible for transfusion will have a key role in reporting both infectious and non-infectious hazards. Blood transfusion centres should be rapidly informed about possible viral or bacterial transmissions so that withdrawal of other components and appropriate investigations can begin. Vigilance of reporting of infections to national surveillance centres also continues. And then it indicates how the full details of the SHOT scheme can be found. That was when it was launched, and its aims and objective and its remit. The first annual report was produced in 1998, covering the period of 96 to 97. And it's perhaps worth now just turning to the terms of reference of SHOT. NHBT 00775940_005, please. Now, these are terms of reference as updated in 2001, but we can see there that the aims are set out of collecting data on serious sequelae, and that reports would be widely distributed. Through the participating body, the information obtained will contribute to improving the safety of the transfusion process, informing policy within transfusion services, improving standards of hospital transfusion practice, aiding production of clinical guidelines for the use of blood components, and collaboration with other NHS patient safety initiatives. Are these terms of reference in 2001 broadly those that were in existence when SHOT was established as well?
Yes. Yes. I think one thing maybe could have been brought out a bit more was the educational function of SHOT in through the annual reports and other educational activities, feeding back to the professions and to the public and to patients what we were finding and what we were recommending to be done about it. Yeah.
In terms of the blood components that were included, we can see at the bottom of the page that it covered transfusion of red cells, platelets, fresh frozen plasma and cryoprecipitate, including any virus inactivated equivalents. Although solvent detergent treated fresh frozen plasma is a licensed plasma product, it would be helpful for comparative purposes if complications were also sent. Adverse events associated with transfusion of components from volunteer donors, family members and autologous blood should also be included. And then if we go over the page, the complications that were to be included are listed as both non-infectious and infectious, suspected or confirmed cases of microbial transmission, bacterial, viral or parasitic, other agents. again, that are they broadly the same type of incidents that were required to be reported from the start of SHOT's work?
Yes, I think near miss came in the second year, but broadly these are the right headings, yes.
And, sorry. And in terms of how the SHOT reporting system operates, the requirement was that reports were sent from clinicians into SHOT, and they were then analysed by a smaller group of experts. Is that right?
Yes, and to begin with, obviously there was a certain amount of, well, the system was feeling its way, and hospitals were a bit unsure. So the first couple of years, not every hospital reported, clearly. But as the numbers grew year on year with confidence in the system, we divided up the different categories of report to be analysed by different people. And I should mention the fact that from the outset we had fantastic collaboration with PHLS. And this would not have worked had PHLS not been on board absolutely from the beginning. And so infectious hazards were reported and analysed by experts from PHLS and then contributed to the final report.
Now, reporting was initially voluntary.
Yes.
Why was that?
Well, because we had no mandate from any other, either legally or from the Department of Health, to make it compulsory. We simply had no power to do that. And actually, we weren't so concerned about that because we wanted SHOT to be seen as a professional activity rather than something that was required by bureaucracy. We thought that would bring people on board better. We were conscious that we would be asking hospitals to report on their own errors, not an easy thing for them to do. And so we had to build confidence with all of the professions at the front line, nurses, laboratory staff in hospitals, doctors in hospitals. So starting a little bit gently, we thought was not necessarily such a bad thing. We, on the terms of reference, we introduced, I think in year 2 or year 3, a nil to report card. So if a hospital truly had no incidents to report, they could send that in and that would still count as a participating hospital. And so we could monitor year on year what percentage of hospitals were taking part. And it was gratifyingly good even before participation became an essential part of hospital lab accreditation, which it did become.
So by the end of 2 years, it was, you've said in your statement, 65% of hospitals were taking part. And then, as you say, it became effectively compulsory through the requirements of the lab accreditation.
Yes.
In terms of what SHOT receives, though, is it right that it still relies on hospitals reporting accurately?
Yes.
So the data of SHOT is only as good as the reports by the hospitals?
Yes, yes. I think we took the view that we were getting so many reports, and they eventually, ended up in the thousands. We had enough to do proper analysis, and most importantly, to produce evidence-based recommendations, because SHOT wasn't simply there to crunch data and produce nice graphs. No, we wanted to do 2 things. We wanted to educate and we wanted to make recommendations. And we refined the process over the years so that it was clearer to whom we were making a recommendation. So some were aimed at the blood services, some were aimed at hospitals, some were aimed at decision makers such as departments of health, some were aimed at the British societies who write clinical guidelines.
Before we get to those recommendations, just one more question on the data.
Yes.
Where there's been an error of some sort, but the patient's died, whether that's because of the error or some other reason. How is that sort of data assessed as to whether or not it falls within the shot remit?
Yes, there's discussion between, because SHOT now has a small team of full-time staff, and the clinicians who support and analyse SHOT data. And so another refinement over the years was where there was doubt, cases could be categorised as probable or possible if there was any doubt as to the cause of death of the patient.
You've talked a moment ago about the recommendations that are made by SHOT, predominantly in the annual report.
Yes.
How do those recommendations reach the bodies that you're making them to? How do they reach clinicians or a particular agency?
Yeah. So the steering group is a large one and meets a couple of times a year. And we managed to get nearly every Royal College and professional organisation and the blood services and PHLS onto that steering committee. I think the only organisation that we never managed to get on board was the Royal College of Midwives, which was unfortunate. But every other professional group was on the steering committee. So it was made very clear that it was the job of the representative on the steering committee to take the report and recommendations and promulgate through their own bodies. And so very often the representative would be somebody sitting on the council or the national committee of whatever organisation it was. And of course, if the recommendation was directed to the blood service or occasionally PHLS perhaps, that was quite straightforward. So when SHOT report came out, it was through NHSBT's clinical governance structure, it was brought for discussion, and the same would be true at JPAC, and it would be fed up in NHSBT up to the executive and the board if there were any recommendations for us.
You've said in your statement it was clearly an unacceptable situation, that there was no national reporting system of transfusion risks before SHOT was established. Why do you think it wasn't established at an earlier date?
I suppose to some extent it goes back to the disparate nature of transfusion services. Would be one thing. Perhaps the NHS wasn't as joined up. Certainly the blood services were not as joined up with hospitals as they subsequently became. All of these made difficulties. Of course, there were no computers. Everything was on bits of paper. But none of these were absolute showstoppers. I mean, they would have made the mechanics of doing it more difficult. But I can't see any reason fundamentally why there wouldn't have been such a reporting system. But I never managed to find any record of one even having been discussed in the 1980s.
As far as you're aware, it had simply never even been raised as something that should be considered?
Not that I've come across.
So those are the questions I had for Dr. Williamson. I'm conscious that I need to see whether any co-participants have anything that they want me to raise. So I wonder if we could take a break. In fact, it's just after 3:15, so...
Yes, well, as you may know, Doctor, if you've watched any of the previous proceedings, at this stage, there is an opportunity for those who are co-participants to feed questions in to Council, and she'll ask them of you when we come back. We have to give time for that to happen. Yeah. So in order to combine time for tea or a break and time for that, we'll come back at 4 o'clock for what will be the last session of the day. I can't tell you how long it'll be. It all depends on the questions that we have.
Of course.
But I look forward to seeing you then.